The Pallium project has evolved into one of Canada's most robust examples of a community of practice. COPs are collaborations of people who share specific interests and practices and work together to advance their specific area of practice. A COP reflects a long tradition of working together in Canada among neighbors and within communities to share resources, energies, and efforts in mutual interdependence of common goals. It reflects a great paradox of our times. The simple idea of diligently working together to reframe the complicated question of how can we afford to provide services to an aging population into one which enables us to navigate the complexity of ensuring that systems of care are available when patients and families need them. In this report back to stakeholders, several collaborators in project activities share insights about the project's work, results to date, and the difference it is making.
It began with, I suppose, a personal passion and some shared vision in my own program in palliative care with some other colleagues who felt that this was something that we could do, that there would be potential for the development of a competency-based education and spiritual care for hospice palliative care. It's never been done before, and we wanted to do it. So this was the opportunity to do it, and I would have to say there was a lovely synergy of people and time and opportunity.
We had the mechanism and the opportunity to do this. We needed dollars to support Dan to do it, but Dan had the wisdom, experience, and ability. And from this, very quickly launched a curriculum. People came to Regina and had this experience, a 12-week experience with us.
Just like healthcare professionals, all religious professionals do not necessarily have enough training or skills in their original training with death and dying and grieving and how to, what are the spiritual issues related to that and opportunities for support. So there is a need for continuing education in that field, and so it was wonderful to be able to send our professional away to get that education.
It surpassed my expectation. It surpassed my expectation from where we actually got it to go to in the time we had. It surpassed my expectation with the people who came to us for training, just how alive they became, the joy that they left with, knowledge, ability, skill.
The degree of enthusiasm that the students have shown, the learners in the summer intensive training units, the learning laboratories that we undertook to test out this curriculum, I think their excitement in the whole process has been quite a rewarding experience, and there's a lot of interest in learning about hospice palliative care.
We immerse them in every piece of palliative medicine, looking at spiritual suffering throughout a continuum of care. So they saw people in the cancer center, at home, in acute care, in the hospice, and even people who were bereaved. And how did spiritual suffering affect every aspect of that continuum?
I think that whole program is significant to help to elevate spiritual care to the point that it needs to be in end-of-life care. I work for a community hospice. We're the psychosocial spiritual component of care. We know we're equally as important to the medical piece of care, and our medical colleagues acknowledge that. But often the medical piece takes priority. The resources, they take priority in resources and things like that. So this, I think, is significant in starting to reposition and position appropriately where spiritual care belongs.
They're just as important, if not more important, because in that last, let's pick a time, last 3 months of life, often there's an awful lot of work that the patient and family need to do, and spiritual or pastoral care are so important for that.
This is part of a national process which is slowly becoming more knit together as people become acquainted with one another, and it's leading probably to a more collaborative and interdisciplinary approach.